Hello, my name is Charlene Hagerman. I am a nurse consultant and I work with the North Simcoe Muskoka Hospice Palliative Care Network. I am going to be doing a short presentation on the clinical frailty scale. So the objectives of this presentation, first I'm going to start with an overview of frailty. I'm going to discuss some social circumstances and implications for frailty. I am going to review the clinical frailty scale for assessment and screening and discuss why we use it. I'm going to review the scoring with the clinical frailty scale, review some tips for scoring with the clinical frailty scale, and scoring frailty in people with cognitive impairment. And I'm going to just wrap up by talking a little bit about whether frailty is responsive to prevention and treatment. So just an overview of frailty. What is frailty? It's a state of increased risk, but no single accepted definition of frailty exists. Often it's associated with low energy, slow walking speed, poor strength. As people age, often they develop many health deficits that can accumulate and present clinical challenges when many things go wrong at once. It impacts higher order functioning, such as being able to do as they please, to look after themselves, interact with others, and to move about safely. I'm going to talk a little bit about just what the biological and chronological age is. So chronological age is actually the number of years that have passed since we were born. The biological age is really dependent on many circumstances or variables that are changeable, such as genetics, lifestyle, nutrition, and diseases. It's our functional age. A quarter of all people over the age of 65 have some degree of frailty. And frailty is more centered around the biological age or our functional age. It's a state of increased vulnerability that leads to increased risk of poorer outcomes after a stressor event occurs. So I'm going to review some of the social circumstances and implications for frailty. So individual circumstances include one's health, income, education, just to name a few. Some family and caregiver factors are the amount of support that someone has. Do they have adequate housing? Are they living alone? Institutional factors may include the design of their housing, whether they're living in a facility such as a retirement home or a long-term care facility, and again, what supports are available to them. Health services and system factors, this might be just how accessible their services are. And I think an underlying theme that I keep mentioning is just what supports they have. Community factors, so are they living in a safe neighborhood? Are they living in a neighborhood that's accessible? And government policies also dictate a lot with social circumstances and how much support there is for a person and their caregiver. So these are all extremely important factors when we're dealing with both dementia and frailty. So what is the clinical frailty scale? It was developed in Halifax, Nova Scotia in the 1990s. It's currently being used in over 20 countries. It's a 9-point scale used to summarize the overall level of fitness or frailty of the older adult over the age of 65. Ideally, it's scored by a physician, a nurse, occupational therapist, physiotherapist, or a psychologist. And it is a judgment-based tool to screen for frailty and determine the degree of fitness one has. The higher the score, the higher the risk. Why do we use the clinical frailty scale? Well, studies in emergency departments have demonstrated that patients with higher frailty scores and higher illness severity have a much higher chance of dying within 30 days than those with low frailty scores and less severe illness. It can be used as a triage tool to make very important clinical decisions when allocating our precious healthcare resources. So this is just a visual of the clinical frailty scale. It has been updated just recently. So you'll see number 1 is very fit, and as the numbers increase or the score increases, the degree of fitness decreases. So we're going to be going into this in more detail. And we're also going to talk about frailty with dementia. So scoring with the clinical frailty scale. So level 1, people in this category are very fit. They're active, energetic, motivated with regular exercise. They're really the fittest for their age. Level 2, this category is people that are considered fit. They might be a little less active than those in level 1, but they have no active disease symptoms. They often are exercising on a regular basis and are quite active for the most part. Level 3, people in this category are considered to be managing well. People who have medical conditions that are not well controlled may be mildly symptomatic and often are not exercising routinely beyond maybe some routine walking. Level 4, this is living with very mild frailty. So people in this category, they're not totally dependent on others for daily assistance, but they might be needing some help. They might be feeling just a bit slowed up, using a cane to walk with, reporting increased fatigue during the day. They might describe their health at this time as being fair or poor instead of good or excellent. And if they have chronic conditions, they might have some mild symptoms associated that can limit their activities. Level 5 is living with mild frailty. And so there's more evidence of slowing. They may be using a walker. Assistance is often required for higher order of activities of daily living, such as managing their finances, transportation, heavy housework, meal preparation, medication. They're often not independent with shopping or going outside on their own. Level 6 is living with moderate frailty. People need help with care of the home inside and out, and often in level 6, people are having problems with navigating stairs. They often need some assistance with bathing and dressing, or they might need to have some cueing in this area. Level 7 is living with severe frailty. So people are most likely dependent on others for personal care. They are often less mobile and may be spending more time in bed. They may be using a wheelchair, and they may seem stable and not at a high risk of dying within 6 months. But level 8, they're living with very severe frailty. They are often taking to their bed for extended periods of time. They can be totally dependent on others for all their needs as they approach the end of their life. And if they were to get an illness, even if it was minor, they might not survive this when they have severe frailty. And level 10 is considered terminally ill. So this is the phase where somebody is approaching end of life and life expectancy is thought to be less than 6 months. Scoring of the clinical frailty is based on current state and not what the baseline is in this instance. So this is just another visual of the scale. And again, number 1 is very fit, and this is actually more the old scale, and then just progressing to very severely frail and terminally ill. So I'm just going to review a few tips when we're using the clinical frailty scale. So again, it's designed to summarize the results of a comprehensive geriatric assessment. It's an important triage tool to assist in clinical decisions that need to be used correctly. So the first point is baseline. So we really need to score according to what the person's normal status is, not when they're in an acutely ill phase. So for instance, if they arrive in emerge with an acute onset of a delirium related to the fall, you're not going to score them on the current event. You're really going to score them on what their baseline is. So how were they perhaps a week or two ago prior to this event happening? It's important to do a proper history. So frailty must be sensed, described, and measured, but not guessed upon, as it is an objective clinical assessment. So trust and verify. So we really need to listen to the patient, but if at all possible, try to verify the information that you're being given with a family member or caregiver. And the reason for this is sometimes patients themselves aren't just as in tune or perhaps as truthful with how they're managing. And this could be just a fear of being taken out of their environment if they're admitting that they're not managing as well. So as I had mentioned earlier, clinical frailty scale is a judgment tool based, a judgment-based tool, and we're integrating what we hear, observe, and use in our own clinical experience when working with the elderly. So we're integrating quite a few pieces when we're doing the scoring. It's to be used on people over the age of 65. It is not validated for persons in the age under 65 or persons that may have a single system disability, such as somebody that's living with quadriplegia. And terminally ill. This is an exception for scoring with the baseline, because in this phase, when people are terminally ill, they are very close to end of life. So the current state presides over the baseline status. And having medical problems does not automatically increase the score to a 3. If a person's symptoms and medical conditions do not impact their life, then their score might be a 1 or 2, even though they do have significant or may have significant medical conditions. So they could still be scoring at a 1 or 2 if they're independent and remain fairly active. And a clinical frailty score of 4. People in this category often complain of slowing down, but are not dependent. So they are more sedentary and often do have poor symptom control. Dementia does not limit the use of the clinical frailty scale. So a functional decline in people living with dementia often follows the same pattern to frailty. And changes in function. So focus on the change of function the person experiences with daily tasks, such as cooking, managing finances, managing the household, managing their personal care. And if a person has always relied on somebody else to perform these tasks for them, then they shouldn't be considered dependent for this activity, because this is their norm. And remember, we are looking for changes. This is just a visual of the intertwining of dementia and frailty. So on the left of this scale, you'll see somebody with normal activity, and it corresponds to a palliative performance scale of 100%. And then as we get down to a 50% functionality, that's when we see, as time goes on, and often it's measured initially in years with the decline in function and becoming more frail. And then as we're getting closer to the end of life, then these changes are actually happening in the realm of months, and then days, and perhaps hours as we get closer to end of life. So scoring frailty in people with cognitive impairment. So mild dementia corresponds with mild frailty. It may include forgetting the details of recent events, but remembering the event itself. repeating the same question or story, social withdrawal, and losing the ability to use routines or cues to aid in their daily routine. Moderate dementia, it corresponds with moderate frailty. Recent memory is very impaired, even though recollection of their past life events can still be very strong. They can often do their personal care with setup and prompting with moderate dementia. Severe dementia corresponds with severe frailty. People are increasingly dependent upon others for all personal care and activities of daily living. And then in very severe dementia, people are often bedfast and not speaking. So just to wrap up, is frailty responsive to prevention and treatment? Yes. Healthy aging can reduce or delay the incidence of frailty. And factors that may influence this, and this is not a complete list, but some of the most important factors that can make a difference: good nutrition, not too much alcohol, staying physically active, avoiding socialization as much as possible, social isolation as much as possible, staying engaged in local community, and reducing fall risks if at all possible. And also a very important one is timely medication review, avoiding of overprescribing, and being aware of drug interactions and non-adherence. So in conclusion, frailty is a state of increased risk that can be compared to others of the same age. The risk of dying increases with age. The risk of becoming more frail increases with age as well. With early identification of increased frailty risk and education to promote healthier, active, safe lifestyles, frailty can be delayed. So these are just a few of the references that I used. You'll notice the name Kenneth Rockwood. He's a physician that works at a Dalhousie University in Halifax that's been very instrumental in developing this frailty scale. So this concludes my presentation, and I hope you've gained a greater insight into the clinical frailty scale and how to use it and the benefits of using it. Feel free to reach out to myself or any one of the nurse consultants in your area with any questions or suggestions for future palliative care educational topics. Thank you.